daughter was diagnosed, the oncologist said it was 1 in a million that she would have the particular genetic characteristic that she had. So, thinking back, what's the probability that I would be here talking about it? It's greater than 1 in a million. I never envisioned being here, but here I am, and that's life. And recently I said that I wished that LCI was available to my daughter when she was diagnosed with lung cancer. And so I've been asked to expand on why I said that. Briefly, my daughter, age 29, was diagnosed with incurable stage 4 lung cancer in September of 2020. She was referred to a pulmonary oncologist at the Hollings Cancer Center, who told us they'd fight the disease to the best of their worldly abilities and hoped that time would bring additional tools to the battle. My daughter, her mother, and I all agreed we were in the best possible place, getting treatment at Hollings, in Kelly's hometown, Charleston, where she was attending graduate school and through most of her disease course was living a normal life. Kelly, who had a rare genetic mutation for which there was no specific targeted treatment, went through 3 different medications, all of which held the cancer back for some level of time. But tragically, she lost her battle in November of 2021. Soon afterwards, at the suggestion of Kelly's nurse navigator, which I thought she was crazy, I became a patient and family advisor at the Hollings Cancer Center, representing a caregiver who had lost a loved one. And unfortunately, on the patient family advisory group, I'm the sole representative of that group, one who was lost. Fortunately, the other people serving on there are all survivors. So, anyway, how could LCI have benefited Kelly and her caregivers? First, let me stress that I believe Kelly did get the best available medical care at Hollings. But I would say that her oncologist was primarily concerned with medically treating Kelly and all his other patients. He was busy interpreting complex genetic data and keeping up with the available treatments. Kelly's nurse navigator, Claudia, became Kelly's second mom, telling Kelly to call her anytime. She also provided Kelly with information, some of which I never saw, on in-house support. But Claudia was providing this information to all of her other patients, so she was stretched pretty thin. One thing I do remember was that Kelly, as her age group knows how to socially network, was texting with a young woman in Sweden who had received a similar diagnosis. I thought this was amazing, but I wondered, isn't there someone close by who she could talk to? Now, LCI has a survivor liaison, and as I understand it, if you're diagnosed and get the information, you call a certain number. Cheryl will call you back within 72 hours.
48 to 72.
48. Comforting you and informing you of all the support services that are available, should you decide that those services are right for you. One of these services is a survivor and caregiver networking group where you can talk with, virtually or in person,
people who are having similar experiences. That seems important. Now, one cannot know if Kelly or any survivor or caregiver will take advantage of the services offered by LCI. That's an independent decision. I will say that in Kelly's case, as we see at this party 1 month before she died, she had a bevy of friends who supported her during the course of her disease. But those friends, even though they loved her to death, did not have a directory of lung cancer resources like LCI can dial on. So one example of an in-house service that was offered to Kelly at Hollings was psychological counseling. Sounds good. Kelly went to a meeting or two, but told me she really didn't feel that there was a connection that was helping her. As I understand, Hollings is working to make available new types of counseling and support, but perhaps back then, if she had contacted LCI, they could have tailored that connection to someone who would have impacted her. Now, as you can see here, as many cancer patients have to deal with hair loss. And dealing with hair loss is seemingly a small matter in the scheme of things, but it was very, very important to Kelly. As I remember, Kelly did receive some advice on how to deal with hair loss, but there was minimal support for funding or finding and procuring a wig. This was largely accomplished through the internet, telephone calls, and out-of-the-pocket purchase. I am pretty sure that if she had contacted LCI, they would have known what to do and what was available. Now, the American Lung Association recently reviewed the state of lung cancer in South Carolina and the nation as a whole. Lung cancer is a leading cause of cancer deaths in South Carolina and in the U.S. However, South Carolina is below the national average in survival and early diagnosis, and near the national average for lung cancer screening. South Carolina does not require insurance companies to cover biomarker testing. And as most of you know, South Carolina has not participated in Medicaid expansion, affecting those with below average resources in South Carolina. So South Carolina is certainly a high-need state when it comes to providing additional resources for screening, treatment, and support. This is especially true these days as the current federal administration is cutting cancer research funding. An example of this was provided by CBS News, who reported a patient who had just qualified to enter a clinical trial that was going to be her last chance effort to slow the spread of her cancer. Her trial was about to start when National Institute of Health funding was pulled overnight and the trial was canceled. These are the times that we're living in. But in summary, there's always hope. And as someone once said, it takes a village to effectively deal with a cancer diagnosis. How to treat, available clinical trials, interpreting complex genetic data, who to talk to, shared experiences and questions, access to survivors and other caregivers, all are things that LCI can help with. I am so glad that these services are now available in South Carolina, and I hope that this meeting will spur the integration of these services at Hollings and at all care centers through South Carolina. Thank you.
is Sue Wayne. I met some of you last June at a SCORE symposium, and I'm really excited and very flattered to have been included today. My survivorship of lung cancers started in June of 21 when I was diagnosed, and that care went through January of 22. It then kind of continued, not as I was informed or expecting, when peripheral neuropathy arrived in February of 22. I woke up one morning and my feet felt like they were walking on 1-inch granite to gravel, you know, the square kind with all the sharp edges, and made me very unsteady on my feet. I had no idea that that was coming. But it also included, from years earlier, my husband's experience with stage 4 metastatic melanoma that was diagnosed in December of 2013. And that's kind of where my whole story begins. We were on a boat. Boats were big in our life. We did a lot of sailing, long-range sailing. And my husband had a meeting in Miami. So we thought it would be fun to take the boat, get down to Miami, do the seminar he was doing, and then go over to the Bahamas for a few months. Seemed like a good plan. On day 2, outside of Charleston, he said, "Hey, took a look at this little spot on my head." And I looked at it, and I said, "How long has this been here?" He said, "Oh, a couple weeks." I said, "You're telling me now?" And there we were in the ocean, heading south. So we watched it, obviously, and when we got to Miami, I jumped on the computer and spent a good hunk of the weekend researching. We did not know anyone in Miami, Florida. And so finding medical care, I depended on the internet, which is an interesting experience. But we found Steve Mandy, who was a dermatologist that was just a few miles from where we were with no car. So we could get a cab over, and he could see us. I'm calling him on Monday morning. He could see us Tuesday morning. So we went, and he said, "This doesn't look good. We're going to do a biopsy." Off it went. We had our seminar. We had a week or so there. Didn't get the results. But finally, we were in the Bahamas when we got a call from the doctor who said, "We finally got the results back, and it's melanoma. Don't wait until March to get back," which was plan A. And he could help us set up whatever we needed to do. And one of the phrases that was very key in that conversation was, "I will help you find someone anywhere you want to go. Oshkosh, back to Connecticut, South Carolina. But you need to know that one of the top researchers in melanoma is here in Miami." And a few of you, I think, know the name. And his name was Jose Lutsky. So we set that all up. We came back to Miami after the holidays and managed to get into the clinical trial for a Merck drug, Mabab, and it later became known as Keytruda. Now, getting into that took some doing because he had not just any old melanoma, he had stage 4 metastatic melanoma in his liver, his lungs, his right shoulder, and his brain. So this is going to be a little more involved. And Dr. Lutsky fortunately knew the right people to get gamma knife surgery for the brain portion. And then he let us know that there was this clinical trial, phase 3, for this Merck drug. And Dick was eligible to get in it if we were willing to commit to be in Miami every 3 weeks for 2 years. The important thing is that the side effects were minimal, and the results had already proven to be 85 to 90% successful. So it was a pretty easy decision to make. We proceeded with the whole thing and did go to Miami every 3 weeks. And went through the whole process. At one of the meetings, we took the dermatologist, who was a godsend in the scheme of things, because he knew all the right people. And this cancer fight is all about connections, professional ones, personal ones, and new ones you make by talking to people. So we were able to meet Dr. Janice Taw at Johns Hopkins University, dermatology department. And Dr. Mandy was on the board of the dermatology department at Johns Hopkins. And so he said, would you like to meet her? Which we said, sure. I mean, this was a person that was a key player in the development and invention, or whatever the appropriate term is, for coming up with Keytruda. We had a couple of great conversations on the phone, on our trips back and forth on the boat, over the next couple of years. We met up with her a few times, a really terrific person. And it was an amazing connection that kind of comes around in a minute. We did follow-up visits after the end of the trial, every 3 months, then 6 months, and then annually with CTs and MRIs and that whole process, and they all showed up clear. So in January of this year, we had a visit with the oncologist down in Miami, and we were informed that he was released from the trial and pronounced cured. Now, that's not a word that shows up often from... He is now today's photographer, my husband over there. So, then my part of the story starts. And that started, again, with a boat involved. And it was just before Thanksgiving. I fell on our boat and broke 3 ribs. And obviously went to the emergency room. And the x-ray showed a nodule on my right lobe of my lung. Had no symptoms, no idea it was there. Not unlike my husband's experience with a little spot on his head. So we, my physician got us in touch with the local experts, and I was pretty calm about the whole thing because I knew about Keytruda, and it was treating non-small cell lung cancer. So I knew the symptom and side effects were minimal, and that it was highly successful. No big deal. Until they said that my insertion for the EGFR gene was not number 19, which is what Keytruda treats. It was number 20. So I had to do the old-fashioned way with surgery and chemo. It turned out well. All indicators were really good. My first checkup showed everything was still looking clear and no problem. And I was very excited for about 4 weeks until I woke up one morning out of nowhere with peripheral neuropathy. And I didn't know that was, well, first of all, I didn't really know what it was. And secondly, I did not know that it was actually a pretty common side effect of chemo of all kinds. And so part of my mission is to make all of you aware. So if you have friends or family members that are getting chemo of some kind, you might want to mention that they should keep an eye out for that, because the sooner you know, the better. I dilly-dallied around for about 4 or 5 weeks before I let my primary care physician know, and we did, a couple prescriptions worth of one drug that didn't do anything, the second drug that didn't do anything. By the third drug, I was getting some physical therapy, which was helping a little bit, and along came Hollings Cancer Center Regatta #1, a fundraising event to raise money for cancer research. And at that, I was involved on the committee, and I also had occasion to meet Dr. Lockhart that day. And we had a wonderful conversation, he and his wife, delightful people, told him about my neuropathy, woe is me, nothing was working. And so, you know, he listened and was kind and all that good stuff. But it set the stage for another event on a boat the next year that changed the situation. And I have to slide in here that had I known about the neuropathy, it would not have changed my decision to go ahead with the surgery and the chemo, because I knew that that was the best solution available. But I would not have waited 6 weeks or whatever it turned out to be to call my physician to get some assistance with this neuropathy business. Well, you know, do the best that I could in the moment, and it got a little bit more tolerable, but really not great, and it is a disruptive, even though kind of an innocuous in the background nuisance, or worse, mostly the sleep that you don't get because you're fiddling around with your feet that don't know what they're doing. After the diagnosis initially, then we needed to search for a lung cancer specialist. And this kind of takes a village. So I called on resources that I knew. One of them was a neighbor from Connecticut who was an oncologist at Yale. He gave me a name of the head of the oncology department for lung cancer up there. And I got a name for a doctor down here. And I know many of you have heard the name Dr. John Rangel. And when I went to my first visit with him, and he told me about this and that, and my EGFR anomaly, I told him in the interest of being transparent that I had reached out to this doctor at Yale. He said, oh, was that Roy Herbst by chance? And I said, yes. I hadn't spoken with Roy yet, but he said, oh yeah, I was talking to him yesterday. We've been working on this other project. We've had him down to South Carolina as a speaker, and I collaborate with him all the time. Now that's a key word, collaboration. Also the connections with Janice Taub and Johns Hopkins, that played into part. And she was in medical school with John, and they all knew each other. And Roy Herbst knew Janice. And so this maze of connections made me very comfortable and confident with where I was with the care. And one feature of both my husband's and my adventures with cancer were putting emails together to friend and family, because there's only so many phone calls that you can take, for one thing, about how are you doing, how are you feeling, what's happening. And so we would write emails about the latest visit and share this with the people that meant a lot to us. And in so doing, we really were able to let them know and anticipate kind of questions they might ask, so we didn't have to get all those phone calls. But one of those messages went to Dr. Mandy, and he, he was really cool about how he summed this all up, and he said, I think you're in the right place. And the reason he thought that, he said, it's a small world indeed, and it shrinks incredibly when you get near the top of the mountain. So I had my surgery, I had my rounds of chemo, got the checkup, and then the neuropathy. And you heard about that preliminary part. And at Hollings Regatta number 2, Dr. Lockhart came looking for me. And he said, I have someone you need to talk to. I'm going to send you her email. She's a doctor in the PT department at the oncology group, and you need to talk to her. So that was Saturday afternoon. Sunday evening, there was the email about Dr. Katie Schmidt. And Dr. Katie Schmidt is a PT specialist in oncology-related services. She started as a PT person for dancers, hence the connection with feet and legs. And she's a really neat person. And one of the first questions that I asked her when she said 85 to 90% of cancer patients of chemo patients get the neuropathy, and I can cure about 90% of them. Now that sounded really good to me. And I said, why don't more people know this? And she said, I don't know, it's hard to get the word out. And that's when I decided that I needed to be the ambassador of this information. So it really does take a village. I have been working with Katie off and on. She has made life much more bearable, not entirely gone, but it's manageable. And there's a bunch of exercises and little electronic pad that I do, every day. And in this whole process of the last 12 years now, there's several things that I've learned and have the honor to have shared with others, and I will share now with you. And this little section I titled, What I Learned About Dealing with Cancer. It made the rest of my life possible. Make the diagnosis your project. Define the issues, research treatments, devise a plan, implement the plan, make it an external problem. Because if it's out here where you're dealing with it, it won't eat you up inside. And the feelings part is another aspect of what goes on. But in the beginning especially, you need to solve the problem. You want to find the best research center that's appropriate for the version of cancer that you have. And if you can't get to it for treatment, then you want to find a local physician that's collaborative in nature and has connections to the latest and greatest research and places. You want to ask questions, source information. And if the doctor objects to collaborating and answering the question, change doctors. Because you really need this sense of village and community to support you. And if the doctors, they can't all know all things about all cancer. So you need to hope that they have a network that's as powerful as yours to get information and support and be able to treat what's going on. Doing research online is helpful because you want to know what's going on. And checking out the doctors and their credentials online can be challenging. And you look at the reviews, dangerous place to go. Because a lot of people like to complain about things. And what I discovered is that that doesn't solve anything. If the waiting room was full, if the doctor was running a little late, if they weren't nice to you that day, they're busy. There's more important things to look for. You want results and plans and good communication. So the other piece I mentioned earlier was to share your journey with friends and relatives and neighbors, your village of people that kind of is in your life anyway, because it's amazing what information can be very helpful to you from those people. And if the patient tends to isolate themselves, that's not going to get a good outcome at multiple levels, not the very least of which is getting good information about the health care that can be available. And I think we now have a new venue of places to reach out to with the Lung Cancer Initiative coming to town. And also SCORE is doing some amazing things with cancer outcome and research, and they've got a list of programs so that the patient leaves the treatment phase and moves into this surviving phase, which has a whole different bunch of needs and hurdles to get over. And they're putting together support materials, and we're getting close to publishing. I did get roped in to be on that committee too. And, so you don't have to go through it alone. There are people that care about you and for you and with you. So that is my word for the day.
Of targeted therapies for lung cancer, which are it's one of the most exciting avenues and what drew me to studying lung cancer, but also seeing lung cancer patients. So before we go into that, I just want to go over some lung cancer survival, what's been going on in the recent few decades. So if we were in the trajectory that we were in the 70s and 80s, we would be at that red line. So what you see on the y-axis is the cancer-related deaths, and on the y-axis, cancer-related deaths, and the x-axis is the years. And so something happened in the 90s that kind of switched the trajectory in a good way. And so if you map out the different types of cancers, what we're seeing on the side there is that the red line is the cancer-related death specific to lung cancer. And you can see that downward trajectory for both men and women. A lot of it can be accounted by smoking education and smoking cessation, but some of our newer targeted therapies and our newer ways to treat lung cancer also accounted for this improvement in survival. So, as others mentioned, even though we say, we improved lung cancer survival greatly over the last few decades, if you look at the difference between lung cancer and other cancers, so just look at prostate cancer. The 5-year trend in survival of prostate cancer went from 68% in the 70s to 97%, which is incredible, right? But if you look down at the lung cancer statistic, it is 12% in the 70s and 25% now. So we've doubled our survival, but if you compare it to other cancers, it is still pretty dismal. And so what I need to say with all this is that a lot more research is needed for us to get to that level that the prostate cancer and the breast cancer have. So lung cancer is the second most common cancer that's diagnosed. So for women, breast is more common, and in men, prostate. But it is, unfortunately, the leading cause of cancer deaths in the United States. So now going into some nitty-gritty with the histologies. So the most common type of lung cancer, when someone says they've been diagnosed with lung cancer, 85% of them are non-small cell lung cancer, and about 15% are small cell. Within the non-small cell lung cancer, they're divided into these different histologies called adenocarcinoma, squamous, large cell. And these just tell us what kind of therapies and what kind of chemo and how we should be looking at these patients, and it kind of helps us decide how to treat them. And so this is a slide I made for a different talk that basically is trying to show all of the kind of the evolution of treatments that have been approved since the 60s. So if you go back to 1960, what we had for lung cancer was best supportive care. So OS means overall survival, and the survival for lung cancer in the 60s were 2 to 4 months. Then chemo came. So chemo improved the overall survival by 6 to 8 months. And a few other chemos, so these are just names of different chemos, and some other agents like chemo, and that improved the survival by 2004 to about 3 months. Then we started getting into the targeted therapies. So these drugs that the erlotinib and gefitinib that I've outlined are for EGFR cancer. They were actually initially used in a very non-specific way, but then later on people figured out that it was specifically good for patients that have EGFR cancer. And so then other drugs got approved, like crizotinib and afatinib, but the tide again turned when we got approval for immunotherapy. So blue there is first immunotherapy that was approved for lung cancer called nivolumab. And Then several other immunotherapies got approved, more targeted therapies, and then we started using chemo with immuno, and then you can see the overall survival start doubling to 22 months. And more targeted therapies and several targeted therapies, many of which I actually have not listed here. And so that's all I could fit in on the right side of the slide. But that's for metastatic non-small cell lung cancer. Now, if you go back to early stage non-small cell lung cancer, we used to have surgery. And then what happened in about 2007 is we started to have some, we started to see benefit to adding chemo after surgery, and we saw some improvement in overall survival. And for patients who couldn't get surgery but had early stage lung cancer, they were able to get chemo radiation. But when we were able to add durvalumab, which is immunotherapy, to this, you can see that the overall survival dramatically improved in the early stage as well. And what we have right now is so much research that's been done over the last 4 years that have added chemo and immunotherapy before and after the surgery, and even targeted therapy after surgery. So tremendous progress. That's, just want to say, going back from the 60s to now. This slide is mainly to show, what the survival is based on the different types of cancers. So most lung cancer, about 80% of lung cancer is caused by either smoking, first-hand, or even second-hand. But we have about 20% of lung cancers that are not smoking related. And that is the area that needs the most research. So we know of some risk factors such as air pollution, radon emitter, some genetic factors, and most of these non-smoking cancers are found in adenocarcinoma. Just want to highlight here, this is not part of what I'm discussing, but if you look on the right there, it's small cell lung cancer, where I feel like a lot more research is also needed, because even with limited stage small cell lung cancer, which is where the cancer is just found in one part of the lung, the 5-year survival rate is at the order of 30%. And then if you have metastatic 5 years, 10% of patients are surviving. So all in all, to show a lot of research is needed for all types of lung cancers. Now, I want to highlight lung cancer screening. It is indicated for people who are between the ages of 50 to 80, currently smoke or used to smoke, and have a 20 or more year history of smoking. And what we have found with lung cancer screening is a stage migration. So we see that in blue there is the advanced stage of lung cancer, and in red is the early stage. So you can see that as people have been starting to get screened, they're finding these lung cancers early. And if you remember what I showed you in the previous slide, the survival is so much better in the early stage compared to the later stage. So it is important to find the cancer. So the types of therapy. So traditionally we have surgery, which is physical removal of the tumor from the patient's body. We have chemotherapy, which are medical treatments that attack fast-growing cells. Then we have radiation, which is high-energy rays that damage or kill cancer cells. We have targeted therapy, which are treatments that target cancer-specific genetic changes used to slow tumor growth and kill cancer cells. Now, I also want to again highlight immunotherapy. As Sue mentioned, it saved her husband's life. So it's medical treatment that helps the patient's own immune system fight cancer. I want to take 1 second to highlight the role of immunotherapy in lung cancer. And this is highlighted by this study called KEYNOTE-024. So this was a clinical trial where they took metastatic non-small cell lung cancer patients who'd never been treated before and were randomized to traditional chemotherapy, which is what we were offering at that time, versus immunotherapy. And this immunotherapy, pembrolizumab, is Keytruda. And when you look at the graph on the right side there, the y-axis is the overall survival, and on the x-axis you go down to the 60 months, which is 5 years. And you see the blue line there. The blue line shows 31.9%. So those patients have never had any chemotherapy. They initially got immunotherapy and they are living. This is metastatic non-small cell lung cancer patients. So that is incredible compared to the bottom there, 16.3% who initially received chemotherapy. So now going into a little bit about targeted therapy. So these can be given alone or be given with other treatments like chemotherapy, surgery, or radiation. So what it does is it finds and targets certain parts of the cancer cell to stop the cancer cells from growing, change proteins in the cancer cells so that the cells die, trigger the immune system to kill the cancer cells, carry chemicals or radiation to the cancer cells to kill them. So I want to highlight here, going back to what I was trying to set up before, which is non-small cell lung cancer, and within the non-small cell lung cancer we have adeno and squamous. Now if you look at the adenocarcinoma, on the right there is a pie chart of all of the known molecular alterations we know of adenocarcinoma. So lung cancer is not just lung cancer anymore. You have to say, do you have a BRAF lung cancer or a red lung cancer? Before I go into the nitty-gritty of testing, going back to a little bit about high school biology, reminding everybody about DNA, RNA, and protein. So DNA, as we know, is the building blocks, the genetic building blocks, that kind of tell can dictate what the organism is going to be. And so that resides in the nucleus, and then that is transcribed into RNA. The RNA gets out of the nucleus, goes into the cytoplasm, and it gets translated to the protein. And the protein is what is doing all the work, okay? So these driver alterations, all of those things I showed you in the pie chart before, are changes in the DNA that causes normal cells to become cancer cells, and that promotes cancer growth. So the type of driver alterations, there are many kinds. They can be mutations, which is a change in the nucleotide or building block of the DNA, and examples of those are EGFR, KRAS, BRAF, MET, and HER2. We can have translocations, fusions, and rearrangements, which is where you have an abnormal rearrangement of the DNA that connects two genes together. So examples of those are ALK, NTRK, and RET. Then you have gene amplifications where you have extra copies of the gene. So what you're looking at with that little picture on the right side is a FISH analysis. And what a FISH analysis is, you're looking, those blue kind of blobs are the cancer cells. And then those red little dots inside that are the number of copies of amplification of a gene called HER2, HER2. And in green is how many you're supposed to have. And so in this cancer, they have multiple copies of HER2 that leads to a HER2 amplification. Then you can have overexpression of the protein, where you have increased levels of the protein usually on the cell membrane. And examples of that is also HER2 and MET. And you test that using this thing called immunohistochemistry. And how you test that is you have an antibody that stains for the particular protein. So on the top is what it would look like if it was negative. And on the bottom is what it would look like if it had many copies, not many copies, but more levels of that protein on the surface of the cancer cell. So how do we test this? So there's two ways. We should be doing a biopsy of a tumor for every patient. And then once we get the tumor, then we can run all these different tests. So as an example, we can run IHC for the protein if it's overexpressed. We can run FISH to see if there's many copies of the gene. But very, very importantly, I want to highlight is we need to be doing next generation sequencing. So next generation sequencing, or NGS, is simultaneously testing multiple genetic alterations by sequencing the DNA and RNA from the tumor. So before, and there are some places in South Carolina that are still doing it, where they're testing one gene at a time. So you're kind of wasting tissue, right, by testing one gene at a time. Instead, if you had NGS and you isolated all of the DNA and RNA, you could be testing all of those things I showed you in the pie chart at the same time. Sometimes there's enough cancer cells that shed into the bloodstream, and they're called circulating tumor cells. And these circulating tumor cells sometimes shed the DNA. So this is the DNA of the cancer. And you can collect that with a blood test. And then you can run NGS-based testing on that. And the turnaround for that is much lower, under 10 days often, while the turnaround is much higher usually for the solid biopsy, which is 1 to 3 weeks. But the difference between the liquid and solid, and that's why I said, everybody needs a biopsy, is that you couldn't really do the IHC and the FISH testing as easily on the liquid. But technology is evolving, and so hopefully we might get to a time where we could identify even more with just a liquid biopsy. So I'm gonna take a while and keep this slide up for a while to show you all of the different drugs that are currently targeted agents that are currently approved for lung adenocarcinoma. So one of the most common ones that we have heard a lot about is EGFR, so that's that green one. So 17% of lung adenocarcinomas have EGFR mutations. And this doesn't include the one that Sue mentioned, which is the EGFR exon 20, and that is that purple part of that pie. And so if you go down to the box there, you can see all the different drugs that are approved for EGFR cancers. And maybe one of the most common ones that you may have heard of is Tagris or osimertinib. But now we have even more with osimertinib combined with chemo. We have other agents like amivantamab with lazertinib. Then we have older drugs called gefitinib, erlotinib, afatinib, dacotinib. And then if you go specifically to an EGFR exon 20 insertion, at that amivantamab with chemo is what is approved. Another common one, alteration we see is ALK alterations, for which there are several of those drugs approved, like lorlatinib, alectinib, brigatinib. And let's see, what else is common? KRAS. So KRAS accounts for about 25% of lung adenocarcinoma. And we knew about KRAS since the 60s, but we've never been able to target it well until a drug was designed specifically for one particular mutation called KRAS G12C. And KRAS G12C accounts for about 14% of lung adeno. So it's not all KRAS mutations, just a specific mutation called KRAS G12C. And now we have 2 drugs approved for it, sotorasib and adagrasib. And then for MET exon 14, we have capmatinib and tepotinib. For HER2 is actually interesting, and this is ERBB2. So HER2 can cause lung cancer because they can be DNA mutations, or they can cause lung cancer because they are overexpressed, so even the protein is overexpressed. So the drug approved right now for lung cancer is Enhertu for that, but there are so many other small molecules and pills that are being studied in clinical trials right now. But just to highlight, these are not what's being studied. These are all the approved drugs. So if I had to put in all the little drugs that are being studied for trials, I don't think, we would have to break it down into each of these different alterations. ROS1, we have entrectinib, repotrectinib. BRAF, we have dabrafenib, trametinib, dabrafenib, binimetinib. RET fusions, we have selpercatinib, pralsetinib. And then NTRK is so rare, it's about 1%. We have entrectinib and larotrectinib. And then the newest kid on the block is NRG1 fusion. That was just kind of approved, I think, either last year or this year. And it's less than 1%, but we have a drug called zenocutuzumab. So there are lots and lots of drugs, and you won't know if you didn't test, right? And imagine somebody with less than 1% and nobody tested, but that drug works for that person. So it makes a difference with that patient, and it may not be something that you commonly find, but for that one person, it would make all the difference. I want to highlight lorlatinib just because it was presented very recently in ASCO, and it just highlights the progress we've made. So lorlatinib for ALK rearranged lung cancer is ALK tyrosine kinase inhibitor, and what they did in this study is they randomized patients to lorlatinib, the drug, versus a very old drug called crizotinib. And I don't think I need to explain this, this graph so much because you can clearly see the difference. So on the y-axis, you're looking at progression-free survival, and which is the time to progression to the next therapy. So these patients are on that first therapy that they've ever received for their lung cancer. And if you look on the right there at the 60-month mark, you see 60% of patients have not had to change any therapy. So at 5 years, for metastatic non-small cell lung cancer, they're just taking a pill and living their lives, compared to 8% with crizotinib, and the numbers are even a little bit worse with chemo. These targeted agents are now moving into the early stage setting. So this is just a summary slide I had made for a different presentation, highlighting how early stage non-small cell lung cancer has changed recently. And basically, all that blue there is just showing how immunotherapy is being used before and after surgery. But if you go down to the bottom right, those two drugs, osimertinib, is approved for EGFR mutated lung cancer after chemotherapy and after surgery, and alectinib is approved for ALK rearranged lung cancer after surgery. So a lot of these drugs that I highlighted on the previous slide are going to come to the early stage setting as well. So just a general considerations and side effects of targeted therapies that are often oral. You can take it at home. There's less off-target toxicity, so it's really well tolerated. But this is one of the most important points, is that they're more likely to work in the brain. And so if we cannot control any lung cancer that has spread to the brain, that's when we run into trouble. So these small molecules, these small pills, they tend to penetrate the blood-brain barrier and control the cancer there. That was just a handout that I found of just some of the common side effects of targeted therapies, like skin reaction, hand-foot syndrome, GI issues, fatigue, and blood pressure. But they're kind of general, and many of these drugs don't have these side effects, and many of these drugs have different side effects. So it'd just be important to know which drug it's going to be, and then talk to the doctor about what the side effects and what is the best therapy for a patient who's been diagnosed with lung cancer. So a lot of research has been done, but a lot is left to do. If you know somebody who's been diagnosed with lung cancer, I think what's important when you seek out the care is to know that there's an availability of a multidisciplinary team. And what that means is all that stuff on that top right there, surgery, radiation, you want to have a team that can incorporate all of those things. And even in a stage 4 setting, we have used surgery and we have used radiation. So having a multidisciplinary team of doctors with different specialties is very, very important. Very broad next generation sequencing of the tissue and liquid is very, very important. Because if we didn't do it, how would we know that you're a candidate for that pill? And so if you got a little biopsy, and it's very hard to get a biopsy of a lung tissue, and you kind of wasted it on maybe just testing one gene at a time, but how would we ever know you have an NRG1, right, if we didn't test it all at the same time? And you want to talk to the doctor about the risks and benefits of each therapy offered, as well as alternatives. And I think this is quite important. You want to know if there's an availability of clinical trials. So a lot of research has been done, but if you look at that pie chart on the bottom, you can see 31% unknown oncogenic driver detected, right? So that pie chart needs to be filled up a lot more, and drugs need to be there for that pie chart as well, where we don't know what the alteration is, and it's probably something that may have a drug one day. And this is just lung adenocarcinoma. not talking about squamous cell lung cancer and small cell lung cancer, and all of those areas need a lot more research. So, thank you so much.